Historically, leptospirosis was first clinically described by Adolf Weil in 1886 as an acute infection characterized by fever, spleen enlargement, jaundice, and nephritis. Years later, in 1914, Japanese and European workers isolated and identified Leptospira as the causative pathogen in severe Weil's disease. Primarily a zoonosis, leptospirosis nowadays affects mostly tropical countries, affecting people with occupational or recreational exposure to soil and water contaminated with urine from an infected animal. Clinical presentation is variable, with the majority of patients having either mild disease or asymptomatic infection. However, an important proportion of patients develop severe, life-threatening illness with multiple organ dysfunction, which is now identified by the name of Weil's disease. Here, we present the case of a 54-year-old man living in Yucatan, Mexico, with the occupational hazard of being a gardener working on public parks. His symptoms started developing 12 days prior to hospital admission, with fever, asthenia, myalgia, headache, and nausea. Other symptoms started adding over the course of the following days, specifically epistaxis, jaundice, hematuria, and oliguria. Upon arrival at the hospital, laboratory findings revealed anemia, thrombocytopenia, leukocytosis, hyperazotemia, hyperbilirubinemia, and hyperkalemia. Due to this data suggesting multiple organ dysfunction, the patient was admitted at the ICU. Given the epidemiological circumstances of the region at that time, the first diagnostic suspicion was for dengue fever, so serological testing for vector-transmitted disease was done, including dengue, chikungunya, and Zika virus. Since all three resulted negative, further array of tests ensued in search of leptospira, rickettsia, hepatitis B and C virus, and HIV infection, as well as autoimmune antibodies. Then again, all tested negative, except for Leptospira PCR, which resulted positive for bacterial DNA in a urine sample. Antimicrobial therapy with doxycycline and ceftriaxone was initiated, and given the patient's worsening of the kidney function with anuria and electrolyte abnormalities, the decision was made to place him on renal replacement therapy with hemodiafiltration. Over the following days, the patient evolved with good outcomes in both clinical criteria and laboratory markers all around. However, serum creatinine and electrolyte disturbances persisted after recovery from the acute illness. The decision was made then to place the patient on long-term peritoneal dialysis before hospital discharge. During follow-up, kidney biomarkers showed evidence of a persistently low estimated glomerular filtration rate and need for dialytic therapy 3 months after the start of the acute kidney injury due to Weil's disease, establishing the diagnosis of end-stage chronic kidney disease. It is of note that previous reports of severe leptospirosis progressing to ESRD in the immediate months following recovery are scarce in the available literature. The few follow-up studies out there, however, indicate a low 8 to 10% incidence of mild to moderate chronic kidney disease in these patients.